So this is the third part of the video of explain why. So in explain why we have covered 20 important explain whys. Okay, so this is the 21st one. So morphine is administered. Wait a minute. I think there is something here. Okay, so morphine is administered in AMI. See, morphine as such is a very excellent and important question. So why and how it is used in AMI? So first is the pain relief. Morphine is an excellent pain reliever. Okay, so in AMI there is an elevated severe chest pain. Okay, constricting pain. So it relieves the pain. Okay, second is the anxiolysis. It has an anxiolytic property to decrease the anxiety and stress in patient experiencing the heart attack. Very commonly done, huh? And third and the most important is the reduction of preload. Morphine decreases the preload, that is initial stretching of the cardiac myocytes prior to the contraction, by causing venodilation that decrease the workload of heart. Okay, so what are the benefits? Morphine in MI: improved patient comfort. Morphine can improve the patient comfort and reduce suffering during the acute phase of attack, right? This is the first benefit. The second benefit: decrease the cardiac workload. By reducing the preload and the heart rate, morphine can help decrease the cardiac overload or workload and reduce the risk of further cardiac damage. Okay, but most important thing that it should be used judicially. Okay, under close medical supervision. Why? Because it can cause respiratory depression. Morphine can slow down the breathing rate, which can be problematic in patients with pre-existing respiratory conditions. And the second is interact with other medication, for example beta blocker. So it interact with beta blocker and affects the efficacy and increase the side effect. So morphine as such is used in AMI. Okay, for this purpose these are the benefits, but it is used in caution. Now a low dose aspirin should not be advised in angina with gout. Now why? Angina with gout, low dose aspirin not used. Why? First, increase risk of bleeding. Wait a minute. As such, this question we will discuss later, because in gout especially all the NSAIDs are used except the aspirin, because increase in the uric acid and all. But okay, but with angina and gout I have a doubt, so we will discuss this explained why in a different way, that low dose aspirin should not be used in. Another question comes as a pregnancy. In pregnancy basically it increases the risk of bleeding and it causes fetal risk. Okay, in fetal risk. And third is another pregnancy complication like APH and PPH, abruption, placental abruption, antepartum hemorrhage and postpartum hemorrhage. Okay, so this is very important. Low dose, where low dose aspirin is given sometimes. Okay, it is given in pre-eclampsia. Because it decreases the risk of eclampsia, and all fetal growth restriction. Because aspirin may help improve the fetal growth in women with a history of fetal growth restriction. So these conditions it may be used, but it is not used or contraindicated or used very judicially. Okay, just because under medical supervision, because of the risk of bleeding, there is a fetal risk, Fetal risk, aspirin affects the fetal development, particularly when taken in higher dose during the third trimester. Okay, so this angina with gout I will discuss later, or you can just text me that how low dose aspirin not to be given with angina and gout. Okay, I'm a bit confused with this. Explain why. Next, ACE inhibitor are contraindicated in bilateral renal artery stenosis. It is a classical question. It is a classical question. Why? How? First, risk of acute kidney injury. Acute kidney injury increases. ACE inhibitors can reduce the blood pressure. It reduces the blood pressure and renal perfusion, which can lead to acute kidney injury or even renal failure in patient with bilateral renal artery stenosis. A very, very important question. It decreases the BP and renal perfusion, ultimately leading to acute kidney injury. Now, there is a decrease in the glomerular filtration. There is an increase in the GFR. What? Uh, there is ACE inhibitors decreases the GFR in patient with renal artery stenosis, which can worsen the renal function and even leading to the acute kidney injury. So this is a classical question which was asked in my time also. Okay, so what other drugs can be used for antihypertensive medication in case of bilateral renal stenosis? It is the calcium channel blocker like amlodipine, clinidipine. Okay, beta blocker can be used to control the blood pressure in combination with even other medications like calcium channel blocker or diuretics. Okay, so here the ACE inhibitors are contraindicated. It's a very important question to be noted down. Even ACE inhibitors are not used in pregnancy, as a blood pressure controlling agent. Right now, what is the danger of using digitalis in patient with low body potassium levels? Okay, if there is a low body potassium levels, first it may occur digitalis toxicity. Hypokalemia increases the risk of digital toxicity, which can lead to arrhythmia. AV block, ventricular fibrillation, cardiac arrest. Okay, so it may lead to digitalis toxicity. It increases the sensitivity to digitalis. Why? Because potassium and digitalis have a competitive relationship. Digitalis has a competitive relationship. Okay. So when potassium levels are low, the heart becomes more sensitive to digitalis, which leads to more digitalis toxicity. Third, worsening of anemia. Arrhythmia. Worsening arrhythmia. Digitalis can worsen the arrhythmia, okay, in a patient who are already in a hypokalemic state. So what can be done? Monitor the potassium levels. Okay, potassium level 3.5 to 5.5 is a normal level. Anything less than more than that, digitalis should be used very cautiously. Then we have to correct the hypokalemia. Okay, we can use even magnesium supplement to correct the potassium. Right, ROMK receptors are there. Okay, which I think you know about this, right? Then another thing, alternative medication can be tried, right? So which can have no effect on the potassium levels. Now, justify the role of diuretic in edema. Okay, so a diuretic in edema, basically what it does, it increases the urine production. Diuretics increase the renal sodium and water excretion, thereby increasing the urine level and decreasing the fluid overload. Okay. The second is reducing the fluid volume. By promoting diuresis. Diuretics reduce the excessive fluid excessive fluid volume that contributes to edema. Third, decreasing peripheral resistance. Decreasing peripheral resistance. Some diuretics like loop diuretics decrease the peripheral resistance, reduces the blood pressure and elevate the मतलब remove the edema. ठीक है. Which type of diuretics can be used in edema? Loop diuretics are the best, ineffective in the loop diuretics are the best. Furosemide, okay, Lasix are used in the acute edema management. Okay, then there is the thiazide. The hydrochlorothiazide are used for mild to moderate edema. In chronic management, thiazides are used, or acute is the loop diuretics. Again, potassium sparing diuretics like spironolactone are used in case of any liver issue. In case of the liver issue, they are also helping the preserving the potassium levels. So I think this you should understand. Now, what kind of edemas that get benefited from the diuretics? Number one, cardiac edema. Cardiac edema. What is cardiac edema? This is basically left ventricular failure. Here the drug of choice is loop diuretics, right? The second is the renal edema. The renal edema causing, for example, chronic kidney disease or nephrotic syndrome. Okay, there the edema is seen in the face part. In the face part. Okay, so here also the edema, the diuretics can be used. Which is the drug of choice, can't say, but again loop diuretics are used. Okay, and the third, the most important, is the liver cirrhosis or the liver cirrhosis related edema. Here the drug of choice is spironolactone to maintain the ascites and edema. Okay, what other things to which we have to see? What other things? The other things are like monitor the electrolyte level, okay, and renal function by monitoring the sodium, potassium and renal creatinine, urea creatinine. Okay. Number two, adjust the dose very carefully and combine with ACE inhibitor or beta blocker to maintain the edema overall. Okay, so this is how a particular diuretic is used in edema. It is a classical question. Again, it may be asked that why loop diuretics is called high ceiling diuretic. It may be a question, right? Now, furosemide is more efficacious than hydrochlorothiazide as a diuretic. Okay, so these are loop diuretics. Again, we have said acute condition, and in chronic condition, thiazide are more preferred. Okay, so a comparison between loop and thiazide diuretic. Furosemide is a loop diuretic which acts on the ascending limb of loop of Henle, inhibiting the sodium chloride reabsorption. Hydrochlorothiazide, what it does? Hydrochlorothiazide is the thiazide diuretics, acts on the distal convoluted tubule. This is ascending limb of loop of Henle. This is descending convoluted tubule. Furosemide has high potency. Furosemide have high potency, and it has higher ability to produce the even they both are acting same, but thiazide have less potency than ये. ठीक है. Faster of action. Furosemide has a faster onset of action compared to thiazide, which takes 30 to 60 minutes, and it will take around 1 to 2 minutes. Okay. So in case of chronic renal failure, there is no urine production is not there, we try for loop diuretics. Okay, so in which cases, in which scenarios are furosemide are preferred over hydrochlorothiazide? The most important thing is acute fluid overload. Okay, furosemide is often used in the emergency condition like acute heart failure, pulmonary edema, nephrotic syndrome. Okay, these places. Second is the severe edema in renal impairment, chronic renal failure patient. Okay, the third is resistant hypertension. With other medication we combine and give the okay. Now, furosemide, the problem with the furosemide, it has caused a higher loss of potassium, sodium, and chloride, leads to electrolyte disbalance. This is the drawback. And for this, monitoring is important. Monitoring of what? Monitoring of urine output, electrolyte level, okay, and renal function is important for how when you are using the loop diuretics. Okay, now again this question is furosemide is a high ceiling diuretic. It is a high ceiling diuretic because it has a high maximal efficacy. High maximal efficacy. So furosemide can produce significant increase in urine production even at high doses. At high doses also, even in low doses it is very good, but in high doses it can cause an excellent increase in urine production. Next is the steep dose curve. Steep dose response curve. So the dose response curve is steeper. Okay, so diuretic of furosemide increases rapidly with increasing doses. As we increase the dose, the action increases, allowing for a higher degree of control over the fluid management. Okay, so what are the characteristic feature? So it is a loop diuretics, we know it in where it acts. Now it is a high potency diuretic and it has a dose dependent effect. Dose dependent effect. The example are torsemide. Torsemide, furosemide was there, torsemide hai, and bumetanide. 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 I think these two are extra, and torsemide I use very regularly in my clinical practice. Okay, now any diuretic proximal to late distal tubules are potassium depleting diuretics. Okay, so it is a vague type of explain why, but still it's important. Now what happens? Why are they are called potassium depleting diuretics? We can explain how. See, number one, sodium and potassium exchange. In the PCT and loop of Henle, sodium and potassium ion are exchange. Okay, sodium and potassium exchange are there. Sodium potassium leading to increased potassium excretion. So this happens in your PCT and loop of Henle. The second, increase flow to distal tubule. Increase flow to distal tubule. Diuretics acts on proximal to late distal tubule, increase the flow of sodium and water to the distal tubule where potassium secretion is stimulated. So overall there is an increased potassium excretion when we use the diuretic. Now which are potassium depleting diuretics? Loop diuretics and thiazide diuretics. They both increase the potassium excretion. The only difference is loop loses calcium, so it decreases calcium level also, but thiazide improves calcium level. The only difference between loop and thiazide is the calcium, not potassium. Potassium, they both excrete the potassium. Okay, so this is very important. Now spironolactone, eprinone, they spare potassium. So they are like selective mineralocorticoid receptor antagonist, so they retain potassium. Okay, but most of the others are decreasing the potassium level. So what are the precautions? We have to monitor the potassium levels. We have to in case of higher potassium depleting, we have to supplement potassium. We have to use the potassium sparing diuretic. This is a very important question. Many questions can be asked from there. Now mannitol, osmotic diuretic mannitol is preferred over the urea and glycerol also. Okay, so in overall mannitol it has high efficacy to increase the urine output and decrease the intracranial pressure. Number two, the duration of action, it has a longer duration of action compared to urea and glycerol, leading to sustained diuretic effect. Okay, it has less toxicity it has less toxicity. Mannitol is less toxic than urea and glycerol, and fewer side effect and less complication. Less toxicity, less complication. It has a better distribution. It has a better distribution. Mannitol is more evenly distributed throughout the body, reducing the risk of localized toxicity. Okay, so overall, what have we done? It has reducing the intracranial pressure. It also helps in acute glaucoma and managing the cerebral edema. Okay, and urea glycerol, it has decreased efficacy, shorter duration of action, increased toxicity. So that's why they both are not so preferred. Okay, now another question of morphine can cause constipation, because it's a very classical question where codeine was used as a cough syrup and codeine was causing the constipation, or any opioid causes the constipation. How it does? Decrease gut motility. Morphine slows down the movement of food through the digestive system, allowing more water to be absorbed and leading to harder dried stools. Okay, so decrease gut motility, then increased water absorption. Morphine increases the absorption of water from the gut, reducing the amount of water in the stool and making it more difficult to pass. Okay, the third, binding to the opioid receptor in the gut. Binding to opioid receptor in gut, leading to decreased release of neurotransmitters that stimulates the bowel movement. So overall, it decreases the bowel movement by these things. Decreases the gut motility, binding to the opioid receptor, decreasing the neurotransmitters which are responsible for gut motility, and increases the water absorption part is very critical and important to understand. Next, there are other factors which lead to constipation. First is the dose and duration. So the higher dose and longer duration of morphine can cause a higher risk of constipation. And number two is your individual tolerance. There is a different people have a different level of tolerance to the opioids. Okay, maybe more susceptible to morphine induced constipation due to individual difference in the opioid receptor density and gut motility. So opioid receptor receptivity is pharmacogenetics, right? So how can we manage the morphine induced constipation? The first is the laxative. We give laxative or stool softener. These are, even you can give osmotic laxatives which actually help in the bowel movement. Second is the fiber supplement. We give the fiber supplements, so it increase the soften the stools and increase the bowel movements, and it regularize it. Third is the adequate hydration, plenty of water. Okay, 3 to 5 liters per day. So prevent constipation by keeping the stools soft and easy to pass. I hope this 30 important therapeutic problems will guide you to help. It covers all of the pharmacology overall. Okay, and there are 20 more. Okay, 50 more, I'll discuss. I believe the way I am teaching you is appropriate and you are understanding it. I am not so fast. You can just watch the videos in 2x. Don't waste time. Okay, and this is for your theory exam only. Okay.